Ladies and gentlemen, from the streets now we're here. Welcome the host for this panel, our host, God knows, Mperegozi.
Thank you so much, Prosper. This is the time of the year again where every man keeps his beard in commemoration of prostate cancer. It's the second leading most occurring cancer in men and also the fourth common cancer overall. It's also contributing 0.5% of the deaths in Zimbabwe. My name is God knows Mperekezo, like what Prosper is said. And joining me today to unpack this burning discussion, we have Dr. Chiura, a specialist urologist. Welcome, Doc.
Thank you.
We also have Dr. Mushaya Manu. Dr. Mushaya Manu is a clinic manager at one of our Cimas Borodale clinic. Welcome, Doc.
Thank you, goodness.
We also have Dr. Chatambuza. Dr. Chatambuza is a pathologist from our Cimas Med Labs. Welcome, Doc.
Thank you.
Gentlemen, the first question that I would like to ask, maybe I'll come to you, Dr. Mushaman. We cannot talk about prostate cancer if we do not know what a prostate is. Maybe you can tell us what a prostate is.
Okay. So in men, we have a gland that participates in our reproductive functions. And this prostate gland, it's quite deep, close to the bladder. And when we talk of prostate cancer, that's when there is abnormal growth of some of the cells in the prostate gland and they begin to spread to other sites. That's basically what prostate cancer is.
Thank you so much, Dr. Mshamanu. He has unpacked it. He has showed us, he has told us what a prostate is. Maybe now coming to the specialist urologist, Dr. Chuaura. Maybe, Dr. Chuaura, maybe you can tell us at what stage do we say this person has prostate cancer? Maybe you can tell us the development up to the stage where we say this person has a cancer of the prostate.
Okay, thank you. I'll start by making a statement that may not make sense initially, but if you live long enough, you're going to get prostate cancer. If you live long enough, you're going to get prostate cancer. So who do we try to diagnose? Obviously, the people with the longest lifespan. So beginning at age 40 in us blacks, we should start screening for prostate cancer. And the screening is usually involving two things. One is a simple blood test called a PSA, and the second is a rectal examination that should be done by any doctor. Doesn't have to be a specialist. It can be done by any doctor. Okay, if we can get those two things done, if there are abnormalities in any of those two things, then that leads to a biopsy. Okay, once a prostate biopsy is done, then that tissue is sent to the pathologist who will examine it for us, and they will be the ones who actually tell us whether somebody has prostate cancer or not. Once we have that diagnosis, then we have to stage the patient to figure out exactly how far along is this disease. Is this disease contained within the prostate, or has it already spread? And for that, we need imaging. And once we have the imaging, then we can determine exactly what we do for the patient.
Thank you so much. I didn't forget you, my audience. Welcome to the show. So, Doc, coming back to you, can you tell us more about this condition as per the signs, the symptoms? You talked about you see the erection and stuff. Tell us more about the signs and symptoms as well as the risk factors for prostate cancer.
Okay, so I'll start with risk factors. And the reality is that the only risk factor that has ever been proven is people who have consistently lived on high-fat diets. Okay, that's been proven to be true. The second is actually there's a genetic component. And especially amongst blacks, we have quite a significant hereditary component of prostate cancer. So if your father, your brother, your grandfather had it, very likely chance that you're going to get it. Okay, so if you fall within that risk factor or that risk group, then one should actually get tested earlier. So moving on now to the people that we've decided that these are the ones that you're going to test. In terms of the risk factors, those are the main risk factors. Okay. Now, moving on to symptoms. Prostate cancer has no symptoms. Prostate cancer has no symptoms. So if you want to pick up prostate cancer early, you have to get checked. That's the only way you're going to pick it up early. Otherwise, if you're waiting for symptoms, by the time you have symptoms, the cancer is already spread. And that's the typical scenario that we as doctors find ourselves in. So we have to educate our populace to come in and get tested early so we can diagnose early and cure, as opposed to coming in late when you have symptoms to just palliate.
Thank you so much, Doc. We are learning a lot. I'm just realizing it today that it doesn't have any symptoms. And also, importantly, is to note that lifestyle is very important. They say genetics lost the gun and lifestyle pulls the trigger. Gentlemen, join us in the next segment where we are going to further discuss this hot debate. Welcome back. I guess we have all grabbed our bottles of water because the heat is going up and up. Maybe coming to you, Dr. Chatambuza, our pathologist. Dr. Chure has talked about the screening of prostate cancer. From your experience as a pathologist, tell us more about the experience of men and the available screening services that you do for men who opt to go for prostate cancer screening.
Thank you so much for that question. Thank you to other panelists that I have here. So from us as Cimas MedLabs, the tests that Dr. Chura said, we have them all. So he said that usually we want to start screening, usually at age 40, with a blood test. That blood test, which is the serum prostate-specific antigen, it can be done in our nationally and internationally accredited laboratories with a very good turnaround times. We also have got pathologists that can, let's say, if a patient who has been screened and has been noted to have high PSA, and also maybe the doctors have done a digital rectal examination and have seen something quite worrying about the prostate, and if the urologist do a biopsy, we also have got the capacity to actually do the histological reporting of that to say this is cancer. And also we are in the process of having those genetic tests that he was talking about for those who have got a strong family history of prostate cancer, so that we can do them and they make them available for everyone who is noted by the doctors to be at risk. So we've got the whole panel of things that are available for our patients.
Okay, coming back to you again, Doc, you have mentioned terms that are a bit difficult to swallow. I see the term biopsy, protein-specific antigen. These terms are becoming very popular. Can you bring it home so that people like me can understand what a PSA is, what a biopsy is, so that the people are well informed?
So, as Dr. Shura said, after the age of 40, the screening can be done by a blood test. So, so these prostate cells, the cells in the prostate gland, they can secrete a certain protein into the blood. All right, such that if they are abnormal, sometimes the protein can be elevated in the blood. It doesn't necessarily mean that if the that protein, which is the prostate-specific antigen, is high, you have got prostate cancer. It doesn't necessarily mean that, but it is a reasonably good screening tool that can be acted upon to really see whether this raised prostate antigen means something. All right, that's when you go for further evaluation, especially by the urologist, and when they see that, especially when there is some irregularities in the prostate gland, the doctors, the urologists, usually take a piece of the prostate gland, right? And when they take that piece, it is then sent to the laboratory where we look at it under the microscope to really see whether the cells there are abnormal, all right, are suggestive of a cancer. All right. And then if it's suggestive of a cancer, then that's when we tell the doctors that, oh, there is a cancer here. And then the urologists and the other doctors, team of doctors, they can do the treatment modalities that are specific for that.
Thank you so much. So you are saying if I take that piece is what is called the biopsy.
Yes.
So if I take a piece of meat from my wife's plate, it's a biopsy, right?
It's a
I have
biopsy.
learned something. Thank you so much. So
Yes.
let me come back to Dr. Chura. When it comes to cancer issues, we usually hear two terms which are a bit confusing: screening and diagnosis. So what's the difference between screening and diagnosis?
Okay, screening is essentially taking a population of people and trying to look for disease within that population. These are otherwise healthy people, they are asymptomatic, they've got no issues at all, and we're just looking to see if we can identify disease in that set of people. And that's where the annual rectal exam and the annual PSA comes in. It's purely screening. These are people who have no symptoms. Once we've screened, and you find an abnormality in your screening, then you try to make a diagnosis. Do these people who have an elevated PSA, the most common reason for an elevated PSA is not prostate cancer. So just because somebody's PSA is high does not mean they have prostate cancer, as the doctor alluded to. So we now need to make a diagnosis, and that's where the biopsy comes in. So no one can be told that they have prostate cancer unless there's tissue that has been taken that says they actually have prostate cancer.
Thank you so much for unpacking that one. So from my own research, I've actually realized that one of the barriers why men fail to show up for the screening service is the comfortability of those screening tests. Do you want to shed more light on that? Maybe you can start, then I come to the pathologist.
Yeah. You know, I see it every day when patients come in. I tell them, look, I've got to do an exam on you. The exam lasts the whole of 10 seconds. Is it uncomfortable? Yes, it's somewhat uncomfortable. It's more embarrassing than it is uncomfortable even. But for 10 seconds once a year to save your life, I think it's worth it, don't you think?
Yeah, it's worth it. Doc, I'm coming back again to you. You said it's uncomfortable. Maybe you can explain it to the floor here. The test that you normally do, the test that you are saying is uncomfortable.
Right. So the digital rectal exam is the test that the most people talk about. But I'll be honest with you, the test that's actually probably more painful is when the phlebotomist puts the needle in your arm to take the blood. That's probably more uncomfortable. So the test that we do is called a digital rectal exam. We have to put a finger into the rectum where all the stool comes out. But we clean that out first, make sure that there's no problems there. And we can feel the prostate there. That's where we can actually feel any areas that are abnormal. What we're looking for, what we call prostatic nodules. Nodules are hard areas. They feel like your knuckle, okay? Normal prostate should feel nice and soft. Whereas if you start to feel anything hard, that's suggestive of a possible prostate cancer. So when we feel that, that tells us that we need to biopsy that patient. So those are the two things. The worst one is the needle.
You have heard it. If you think prevention is a problem, then get the disease. So those 10 seconds are definitely going to save your life. Doc, in a few seconds, you can tell us your experience.
Yeah. So additionally, I think most of us, we go for our annual medical checkups, and I don't think the needle is really one of those things that is stressing. And I think maybe the needle is 5 seconds actually to have a blood drawn from, and a lot of you, I believe, you're blood donors. You have had these needles put in your veins. So it's not one of the worst things. It's quite easy. Most patients, they don't complain after having a phlebotomy or after having a blood draw. So I think these are quite simple screening tools that are available that anyone can actually do.
You have heard it. The things that we feel like they are difficult are the same things that are going to save our life. The discussion is getting hotter and hotter. At this juncture, let's take a commercial break. Welcome back, gentlemen. We are now in our final segment where we are talking about the cancer of the prostate. Dr. Mshayamano, tell us more. How can one help himself to reduce the risk of them being affected by cancer of the prostate?
Okay, thank you for that, good news. So issues around mitigating the risks of getting prostate cancer. There is a lot of debate about some of the things that have been proven, other things that have not yet been proven. But we are looking at lifestyle, basically. The diet that you take mainly. So a high-fat diet has been proven to increase risk of getting prostate cancer. And trying to reduce the amount of fat in your diet can actually reduce your risk. Other issues that are more general and reduce cancer risk across the board include reducing smoking, alcohol intake, reducing alcohol intake, and being physically active and eating healthy fruits and vegetables. All those things tend to reduce cancer in general.
Thank you so much. And I was actually reading this report, which was actually saying physical inactivity is now another second form of smoking. So, gents, we need to be very physically active. So, coming back to you, Dr. Chura, you mentioned screening and diagnosis. So, if one is diagnosed of a cancer of the prostate, what are the chances of survival, and what are the treatment options available?
Okay, thank you. As I mentioned earlier, once we've made the diagnosis, then we do some staging so we can ascertain how advanced is this disease. So the treatment is really dictated by how advanced the disease is. So let's just start with localized disease. In other words, this cancer is, as far as we believe from the imaging and everything we've got, is still within the cancer, is within the prostate itself. So if it's within the prostate itself, we essentially have 4 basic treatment options. One, believe it or not, is to do nothing. And that really depends on the age of the patient and the patient's comorbidities. If you've got a patient that's got massive heart attacks, has had a stroke before, they may die of something else before they ever die of their prostate cancer. So we may not even do anything. So that doing nothing is one. It's called watchful waiting. Second option is to actually remove the prostate. It's a procedure called a radical prostatectomy. Third option is to do what's called radiation therapy. And radiation therapy can be done in 2 forms. One is what's called external beam, which is done with beams that we send through the body from the outside from a machine. And the second is what we call brachytherapy or brachytherapy, where we put these little radioactive pellets into the prostate. So those are the treatment modalities for organ-confined disease. Now, what if the disease is already spread? So once the disease is spread, doing any of those other treatments is not going to help because the disease is already gone. So in those patients, we're doing what's called palliative treatment, where we're essentially trying to keep the patient alive as long as we can and as comfortable as we can. And mostly that involves hormones or hormonal treatment.
Thank you so much. Maybe you may also want to tell the audience, and including myself, the relationship between the risk of getting the cancer of the prostate and your sexual activity.
Okay. So this is always one that's brought up because I think people are taking these articles home to their wives and telling their wives that the article says we need to have sex every day in order for us to live. Now, there is some truth to that in that it's been shown that people with increased sexual activity actually have lowered amounts of prostate cancer. So there is some truth to it. The studies are not quite definitive yet, but they are inclining to suggest that inactivity of the prostate, where when you ejaculate, a lot of the fluid comes from the prostate, inactivity of the prostate, or just inactivity basically leads to potentially increased levels of prostate cancer.
Thank you so much. Take note, you didn't say sexual encounters with multiple sexual partners. You just talked about your activities, not the number of partners. Take note of that, because I learned that people are now going and actually having sex with other people, having many sexual partners, which then becomes another challenge is in relation to sexually transmitted infections. Dr. Chatambudza, tell us how often can one come for these screening exams at your med labs?
So I think the recommendation usually from the urologist is once a year. Just once a year. Once.
Once a year.
Yeah.
You have heard it, gentlemen. Those 10 seconds once a year are definitely going to save your life. Dr. Mshaman, our clinic manager, what then is the society doing in relation to provision of services aligned to prevention or management of prostate cancer?
Okay, so Cimas Medical Aid has got a package which we call an annual wellness benefit for all the members. And usually in the database, the principal member and their date of birth and so forth is captured. And once a year, on their birthdays, they are sent an SMS message congratulating them on their birthday, but also reminding them to visit any Cimas clinic to have that annual wellness check. And that annual wellness benefit is part of the medical aid package. And they come to the clinic, they go through the processes that we've already mentioned to try and screen for prostate cancer. So that's the examination and the PSA. And it then allows us for further referral if there are any abnormalities. And we have relationships with practitioners who then manage the condition if we identify it. And again, this is part of the package of benefits under Cimas Medical Aid.
Thank you so much. My last question, Doc. I know that this disease does not affect the physical well-being of an individual only. Do you have any suggestions or any take-home message that you can give to the families who are taking care of people living with the cancer of the prostate? Because I do understand these guys, they also need some psychosocial support services. What's your advice on that?
Yeah, no, that's a very, very valid point. And I think that goes across boards, regardless of what cancer you're dealing with. I think the biggest fighter of cancer in general is actually the mind. If I have two patients that come in to see me, both diagnosed with prostate cancer, one has got a positive attitude, the other one's got a negative attitude, their head's down, they're depressed. This patient that's depressed is not going to do well. So if you can get family support to rally around this person, keep them positive, optimistic, they generally do quite well. And the other thing is a take-home message for prostate cancer. Of all the cancers that are out there, it's actually a very slow-growing cancer. There are far more rapidly growing cancers than prostate cancer. So come in, get tested. It doesn't always necessarily mean you get treated. It may mean that we just watch you, but at least we know what we're watching.
Thank you so much. I think at this juncture, we now need to invite the floor to ask questions. So, gentlemen, the floor is now open for questions, and these guys are definitely going to provide us with the answers. So, if you have any question, the mic is there. You get the mic and shoot.
Okay, so I've been to the streets and I've been asking people, very few people have got knowledge about prostate cancer. But then you came into the issue of extinguishing the fire at home. Does it extinguish the fire? Because you were talking about sex. You said those that have frequent sex might. It was not. It's not scientific. But does it also, if you have got prostate cancer, does it extinguish the fire now? Does it make the man useless? He can't have sex anymore. Does that affect men when it comes to his sexual activities?
That's a great question, Doc.
Yeah, no, thank you for that question. Unfortunately, it actually doesn't extinguish the fire. And you heard me say unfortunately. And the unfortunate bit is that now when we want to treat them, the only thing they can think about is extinguishing the fire. And some of our treatments do affect their sexual ability. And so because they're still sexually active, they don't want to get treated because they want to preserve this. And we actually have to have honest conversations about, do you want to preserve your life or do you want to preserve this part of your life?
Thank you so much, Doc, for responding to that. And I'm also learning that screening is very important. It's like taking your vehicle for what? For service, for a service, so that that fire that you mentioned won't be extinguished. And also to support men to go for screening, we have partnered with Elion. So they are giving away 500 mils of oil to every man who is going for a prostate cancer screening at any of our Cimas med labs. So this is a sign that the discussion that we are making is very, very important. Maybe we can have another question.
Maybe just a point of clarification. So you said one of the treatment methods is to remove the prostate. So do you mean if the prostate is removed, then the engine might not rev? Is that the case, or it doesn't affect the erection?
Okay. Yeah, I like all the analogies of the engine and so on and so forth. So anatomically, the prostate, where the prostate sits, and the nerves that go to the penis and allow the penis to get erect are right next to each other. And so when you have to remove the prostate, if we catch it early enough, we can do a procedure called a nerve-sparing prostatectomy, where we literally push the nerves away and we remove the prostate, leaving the nerves intact. And as you correctly say, the engine can continue to work.
Doc, now the story is getting more to the bed than to. So I think it's time we get over this idea. I think it's young people who are full of engines and. So let's move it. Let's move it to the other side where we hear men who are serious about life, men who care.
We have a greater mileage.
All right. Thank you so much, doctors. We've been assisting us in trying to explain what prostate cancer is. I've got one question for you. Maybe it's just a follow up to what Becky has just asked. Are there any side effects of a surgery of the prostate? Yeah.
Yes, there are side effects. And there are two side effects that we worry about the most. One is because where the prostate is located, it's located very, very close to what's called the external sphincter. The external sphincter is that muscle in your body that when you want to urinate, like now you want to urinate, but it's a socially inopportune time to go to the toilet, and you have to hold that urine. That muscle that you squeeze to hold that urine sits right next to the prostate. And immediately after prostate operation, that sphincter can be quite loose and damaged. So immediately after surgery, it's not uncommon for people to have some incontinence or leakage of urine, particularly with what we call stress, when they stand up, when they cough, when they sneeze. And that generally will get better the further away from surgery they get. So that's one complication. The second side effect is, as he mentioned, when people come a little later and we're trying to do operations on prostates where the cancer is already now pushing on those nerves, we can't save those nerves and we've got to take everything out. So there is the risk of erectile dysfunction. But remember, in urology, for every one of these side effects, we typically have some sort of a cure. Okay.
Thank you so much. Just another follow-up question. What's the use of the prostate? Why can't we remove it before we're even getting that high risk of dying early? What's the use of the prostate? Because if it can be removed and still I can survive, why have it anyway?
You guys want to take it?
I think you take that one.
I feel like taking all of it.
Yes, take them.
So the prostate produces a fluid that actually protects the sperm during during sexual intercourse, and after ejaculation, the vagina, where the sperm have to travel to get to the egg, to fertilize the egg, they need a protective coat. And that protective coat is provided by the prostate, by that prostatic fluid. And so the only time we actually need the prostate is during our reproductive years. Once we've stopped having children, we actually don't need the prostate at all. And so if the prostate was sitting here, we would all walk around with a little digit that was shortened because it would be so easy to get to. The problem is it's in a very difficult location to get to. And so removing it is actually very difficult.
Beautiful. Let's give a round of applause to our doctors once again. Unfortunately, you can't sell it as a kidney as well, where you say, I've removed my prostate, let me sell it to someone. You can't. So from that side, I think the questions are more of sense. Do we have anyone here with a question? Please let it not be about sex. Let it be about prostate cancer. Someone from this end. From that end? Yes, we have a question.
Thank you so much to everyone who facilitated this talk. I think the 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 major conception, like understanding of what prostate cancer is that it mainly affects old people and old men. So I think the most interesting part about being a young person and having this conversation is I want to ask, how prevalent is it for young males such as myself and those that are also in the audience to actually get prostate cancer, and how serious can it actually be and affect us? Thank you.
Yeah, so as Dr. Chura said, the prevalence or the incidence increases as someone gets older. All right. But of course, for the younger people, we are usually worried, especially when there is family history. Maybe in your family there's somebody who got prostate cancer much earlier, or if there are those other mutations that we talk about. And also, I think there is some relationship, especially maybe if you've got family relatives that had breast or ovarian cancer as well. So I don't have the exact data. I think Mr. Chura may help there, especially in our setting, as in how prevalent is it, especially in those who are younger than 40 years.
It's a good question. I'm not sure it necessarily just applies to prostate cancer, sadly. I trained in the United States, and so most of my information is literally from there. And in the United States, it's very rare to see somebody under the age of 40 with prostate cancer. It's not so rare here. And we are having conversations about how we might be able to try to get a sense of what a normal PSA is in our setting. Because the standards that we're using, even if you send a specimen to Cimas lab, they've got a reference range. Their reference range is an international standard. And if you look at the population that was used to derive those international standards, 95% of those people are white. So we're using data that doesn't necessarily apply to us. And so we need our own data. And one of the things we're trying to see how we can do is to arrive at normal PSA values for people in their 20s, 30s, 40s, 50s, 60s, 70s, 80s, 90s for our own population. Because then we can start to say, okay, look, your PSA is 3. That's normal according to their lab. But at age 35, your PSA should be less than 2.5. And we can start to pick up more of these patients when they're younger. The other reality is that patients who are younger, and it may have to do with the fact that they're diagnosed later, but they tend to die quicker than somebody who's older. Now, we also realize that patients who are younger tend to have even more aggressive disease than patients who are older. So it behooves us to catch the patients that are younger rather than the ones who are likely going to die of some other disease in their 80s. So that's a very good question.
Thank you so much, Doc. I have a question. So, as we grow up, I remember when we were in grade 1, grade 2, in terms of, I would say, the power, when you urinate, the power will be kind of high. I remember we used to even write our names using what? Using urine, but the power kind of decreases with age. Could that be a sign?
That's a really good question again. What you are describing is actually a more common entity called benign prostatic enlargement. As men age, all of us, our prostates get bigger. And the tube that you urinate through is called the urethra. That urethra goes through the middle of the prostate. And as the prostate gets bigger on the outside, it also squeezes the urethra on the inside. And so that slows our urinary stream. We don't empty the bladder as well. We start going to the toilet more often. We start getting up at night to urinate. People start straining to urinate. All of those symptoms are related to prostatic enlargement, which usually has nothing to do with prostate cancer. So there's a misconception out there, which we need to correct. And that misconception is that, I don't have a prostate problem because I can urinate fine. That's not necessarily true.
Thank you so much, Doc. I don't know if we still have more questions from the audience.
They might not have, but I want to ask the young people that are this side there on the two options. The one where someone puts a finger and where you get blood drawn. Which one would you choose?
They're not options.
Oh, they are the only two.
We need the two. So I'll tell you why.
Uh-huh.
25% of people can have a normal PSA
Uh-huh.
and still have prostate cancer. 25% can have a normal rectal exam and still have prostate cancer.
Okay.
So if you want to maximize your chances of picking it up,
Yes.
do both.
You've got to go about how many of us are willing, starting with yourself. I'll still come back to you. Are you willing to have someone put a finger in the rectum?
Thank you for the opportunity. For my sake, I'm willing because it's for my health, it's for my own good. So I'm willing to do both.
Madzokera Kumba, will you tell madam that this is the process that I went through? Are you willing to tell the madam as well?
I think it's a bit embarrassing, but for them to know the process or for time when there's side effects, I think I should just tell them. I'll tell them.
Beautiful.
With the way I take care of my car engine and with the knowledge that I've gained here, definitely I would go and do that.
Thank you very much for that insightful presentation, Dr. Chura and the other panelists. I think we have all heard that it is important for us to go for screening so that there's early diagnosis and possibly there's good health outcomes. There's also another thing that I want to ask Dr. Chura. Other than prostate cancer, that is we are talking about. Yes, it's one of those leading cancers in the population of men. Can you tell us more about testicular cancer? I also heard that it is associated more with younger people than older people. So for the benefit of my colleagues here who are younger than me, so that also they take care of themselves as far as testicular cancer is concerned. Thank you, Doc.
Thank you for that question. But sadly, it does not eliminate you from the group. So testicular cancer has what's called a bimodal distribution. Typically, ages 18 to about 35. That's the primary risk factor group. But then there's a second group in their 60s and 70s, okay? They tend to get different cancers, but they both are testicular cancer. In the younger age group, testicular cancer is typically a painless mass in the testicle. Again, no pain associated. So if you're waiting for pain and you think you're going to pick up cancer, you're not going to pick it up early. So it's a painless mass in the testicle. And so if you feel your testicles, which as a young person, I generally tell teens that starting at age 16, you need to, in the shower, in the bath, feel your testicles at least once a month. In the same way that women do breast exams once a month. Our boys should be doing testicular self-exams once a month. And what you're feeling for is anything that's hard. You feel anything hard, you need to get seen by a doctor, okay? The same thing is true with our older men. If you feel anything hard in the testicle, that shouldn't be there. That may well be a testicular cancer. In this first age group, this age group tends to get what's called non-germinous cell tumors. And those tumors are actually very, very treatable. Testicular cancer is probably one of the most treatable cancers that we have. The success rates are in the 80-90%, even in cases of metastatic disease. So it behooves us to try and just pick it up early, get it taken care of early, and you can move on with your life normally and forget about it. In that older age group, those tend to be lymphomas. And the problem with our older gentlemen is that they tend to wait a long time to come in. And so I can only encourage you do genital self-exams. And if you see anything there that's abnormal, please come in. And I'm going to digress for 1 second. Penile cancer is something we see more than testicular cancer. We see far more penile cancer. And all the penile cancers we see, they come in very, very late. I mean, you'll be alarmed at what we see when the patients come in. And you're asking this gentleman, how come it took you so long to come here? So please, don't be embarrassed. If there's something there that's not right, please go and see your doctors, yeah? Thank you.
Wow. Thank you so much, Doc. Thank you so much, gentlemen, for sharing, for asking those questions. I'm sure we are running out of time. Maybe I'll ask the gentleman here maybe to share with us their last words. I'll start with you, Doc.
Thank you. So I think the word here is please embrace screening as early as possible, and it's something which doesn't take time. 10 seconds, 5 seconds, you get your results once a year, and we try as much as possible to make sure that we identify the cancer early enough and make sure we have a healthier society.
Thank you so much, Doc Mshaman.
Thank you. So again, it's in agreement with what we have shared already. I know that socially as men, we are trained to grow up as macho, and that tends to sort of make us less likely to go for health screenings, for health checks. But that narrative has to change when it comes to healthcare for men. We cannot continue to be macho and watch things happening and present late. So the message is really, let's try to be proactive as men for our health. Let's go get screened, and we'll be a healthier community. Yeah.
Thank you so much, Doc Mshaman. Our specialist, your last words.
So, first of all, thank you for having me on here. It's been an honor. The month of Movember, and I noticed I didn't say November. The month of Movember is a worldwide movement. It's called the Movember movement, and I encourage you all to participate. Some of you already grow nice beards already. Others of us struggle to grow anything, but we will certainly try in the month of November to grow some hair in our face, just in recognition of this month. There are three main foci for us in terms of Men's Health Month. One we've really spent a lot of time on, which is prostate cancer. We talked somewhat about testicular cancer, but the one we did not talk about, which actually is killing a lot of men, is mental health. There is a mental health crisis amongst men worldwide. It's not unique to Zimbabwe, it's worldwide. And these are issues that really, really need to be talked about because they're real. And the other thing about that I'd like to just leave us men with is that if you look at the studies, when a man is diagnosed with cancer and that man dies, the chances of his family falling into poverty is extremely high. So we have a tremendous responsibility to take care of our health for ourselves, but more so for our families. Thank you.
Thank you so much, viewers and the audience. You have heard it all. The importance of taking your engine for a service is very, very important. I encourage you to participate in this Movember, also on our Movember run that we're also going to be hosting on the 26th of November. Countrywide is going to be physical and also virtual. It's going to be physical in Bulawayo and Harare and virtual worldwide. Thank you so much for being with us, and thank you so much for taking this message home. You can actually get in touch with us on the details that are provided on the screen. Good day.